Good afternoon, everyone. Welcome to today's presentation in the Alzheimer's Disease and Related Disorders Geriatric Healthcare Series. For those of you who have been here before, glad you could get back, and for those of you who are new, I'm glad you could join us. I'm Michael Vidiello. I'm the co-director of the Northwest Geriatric Workforce Education Center, and we're the major sponsor of this series. I'm pleased today to have our speaker, Dr. Tatiana Sadak. She's an associate professor of nursing in the psychosocial and community health department. She's PhD prepared in geropsychiatric nursing, nurse practitioner, excuse me. She's also a dementia specialist and an associate professor of geriatric mental health and an undergraduate program director at the University of Washington School of Nursing. Dr. Sadak's research, clinical work, and teaching are focused on promoting dementia care partners' engagement and activation, formalizing and strengthening the partnerships between clinicians and dementia patients and care partner teams, and supporting dementia patients and their families in their journey. So she's particularly well-versed in being able to talk about detecting and managing multiple chronic conditions in people living with dementia. Dr. Sadak.
Thank you for the introduction, Michael. Good afternoon. Thank you very much for taking time out of your busy day to be here. So today we'll talk about multiple chronic conditions, and we'll start with a general overview of what do we know about multiple chronic conditions and people who are living with dementia. I want to bring your attention to some abbreviations. So PWD is a person living with dementia, and MCC is multiple chronic conditions. We'll also talk about ambulatory care sensitive conditions in people living with dementia, and I'll tell you a little bit about different measures of multiple chronic conditions. I'll point out some gaps that currently exist in the literature and in our understanding of these phenomena and some potential solutions. I will share with you some of the original research that's just coming off hot off the press. We're just wrapping up a study that took a very in-depth look at multiple chronic conditions in people living with dementia, and you'll be some of my first audience to hear about our preliminary findings. So a few more definitions. So here you're looking at a slide of two terms, comorbidity and multimorbidity. And traditionally we think of comorbidity as an index disease. So in our case it would be dementia, and the effect of other coexisting conditions on this index disease. So when we talk about comorbidity, we're presuming some degree of hierarchy. The term multimorbidity came in a little bit later, and it's looking at two or more chronic conditions and how do they affect a patient. So when we talk about multimorbidity, our outcome is the patient and the effect on the patient. When I talk about comorbidity, the outcome is the index disease. So this is just some semantics to introduce you to the literature. So we're going to take kind of a bird's eye view on multiple chronic conditions in people living with dementia. And there are a lot of people living with dementia around the world. So this is a really, really important issue. We as a society are aging, we are living longer. And the longer we live, the higher the prevalence of dementia. So for people who are living with dementia, on average, they have about 4 multiple chronic conditions, where age-matched adults without cognitive impairment have 2. So the prevalence of chronic conditions might be slightly higher in people living with dementia. 91.8%, almost 92% of all people living with dementia have at least one comorbidity. But 16.9% have 6+ comorbidities. And these are the people who require a lot more resources from our healthcare system, who require a lot more attention, and who require real special approaches. And I will kind of tell you in more detail why this is a very important group of folks. In fact, anybody who has more than 2 comorbidities would require a lot of extra resources and attention and special approaches. Why people with dementia represent special challenge? A lot of you are clinicians, and you know from your own clinical work, I will give you some data from my research. Comorbidities in dementia and exacerbation of acute and chronic conditions tend to have a very ambiguous presentation. It's not textbook, it's almost never clear-cut. Very frequently, exacerbation of a variety of comorbidities will present as increased confusion, falls, loss of appetite, dehydration. And I'll give you kind of lists of more ambiguous symptoms you would see in your research and clinical practices. So when the presentation is so ambiguous, it's very difficult to identify the underlying cause. And it's frequently very difficult to even think that it is the comorbidity that's manifesting itself. A lot of times, clinicians, family caregivers may be thinking this is just normal progression of dementia, just exacerbation of dementia as a disease, and not early warning signs of some underlying issues that are happening. So a lot of times, comorbidities and exacerbation of comorbid conditions, the diagnosis is delayed or missed. And care partners of people who are living with dementia, their family members, friends, they're frequently really not taught by us clinicians how to recognize and timely report exacerbations of chronic conditions or appearance of new comorbidities. Oops, what did I do? Help. So I pushed the space bar instead of the sidebar, and everything went away. So my apologies, we're getting some help here. Okay, so when we are not able to diagnose a multiple chronic condition in a patient, I'm so sorry, I totally clicked out of everything. Okay, so when we're not able to diagnose multiple chronic condition in a patient, then we are, oh, nobody can hear me? Oh no, do not press the bar.
I think because you hear her, but can you? Yeah, but just like
Okay, if you
have the slides.
okay,
Still like
okay, just bear with us for a second. My apologies, technical error. So as I misdiagnosed the space bar for a bar that would advance slides, you know, we could misdiagnose exacerbation of chronic conditions. Oh no. So bear with us for a second. Keep your hands off this. Yay, we're back. So I'm going to keep my hands off the space bar. My apologies, everybody. All right, just this. Yes, I've learned. All right. So what else do we know about multiple chronic conditions? Again, very challenging for primary secondary care. And what's important to understand with dementia is an index condition. So when somebody has dementia, it really affects not only manifestation but management of all the coexisting diseases. So for example, somebody with cognitive impairment is no longer able to really manage their own self-care, healthcare, not able to follow through with medication regimen, not able to follow through with complex medical regimen, really requiring help of a professional or an unpaid caregiver or care partner. Also, chronic conditions in somebody with cognitive impairment may exacerbate the presentation of cognitive impairment. For example, people who are living with diabetes or asthma or COPD, when those conditions, chronic conditions exacerbate, frequently we would see exacerbation of cognitive impairment also for somebody with those conditions. People with multiple chronic conditions therefore have higher rates of hospitalization, mortality, institutionalization, and much higher healthcare costs and much poorer outcomes. So what we do know, and here I'm showing you some data that's based on the medical claim reviews of 9,000 people with dementia and 28,000 people who are of the same age and gender and kind of matched demographically, is we're looking at higher prevalence of diagnosis of some chronic conditions. And here in a graph on the left, you're seeing Parkinson's, stroke, insomnia, incontinence, pneumonia, fractures, and injuries. Based on medical data claims, those diagnoses are found more frequently in people with dementia. What's interesting is conditions as vision problems, hearing problems, diseases of musculoskeletal and gait system, lipoprotein disorders, and hypertension seem to be diagnosed less in people with dementia. My mic is muffled. We're moving the mic right now. Oh my goodness, lots of difficulties. Please give us feedback if you could hear me. So we don't think that people with dementia have fewer cases of visual and hearing impairment. What we do think and know is that people with dementia are underdiagnosed with those conditions. So what does it mean? If somebody cannot see and hear you well, then our clinical assessment of their cognitive impairment can be completely off. And by correcting visual and hearing deficits, we could be helping the person, in fact, to improve their cognition. So this is a very important seminal study, and for us as clinicians and researchers, it's very important to be aware that we need to pay very special attention to visual hearing impairment and diseases of musculoskeletal system in terms of prevention and reducing the burden of comorbid symptoms for people who are living with dementia. All right. What are some major gaps? I'm not going to read off the list. You'll have the slide. There's lots of gaps. I will point out some of the most concerning gaps is we really don't understand how to best structure our healthcare system and kind of how to best coordinate the healthcare to address multiple comorbidities in people with dementia. And we don't yet have good evidence about how to best deliver services to this group that has very high needs. We also don't know enough about the views of care partners and people living with dementia, about the challenges and of living with multiple chronic conditions, about interaction with healthcare system, and about the opportunities that they would like to see available to them to improve their access to healthcare and improve the quality of their healthcare. More gaps, lots of gaps in this field. We don't know much about how to best integrate and offer care coordination that actually results in reduction of readmissions of people living with dementia and multiple chronic conditions. We don't yet know how to optimize communication between outpatient and patient clinicians and care partners, and to really harmonize and create best care management programs for care partners who are delivering this health and care management at home, how to best train and coach those care partners. And we have insufficient evidence about the relationship between dementia and a course of specific chronic conditions. We know that prevalence is high, we know that risk is high, but we don't know the nuances to a degree that we should. So one of the reasons why we don't have enough data, even though plenty of articles are published on the topic, in the literature reviews that you have included with the slides, there's some really significant systematic reviews that I'm listing. So why am I telling you we still don't have enough data? I believe that one of the biggest problems is a problem with measurement. Very recently, just a few months ago, at the end of 2017, there came out an article which I believe is kind of seminal in our understanding of multiple chronic conditions and dementia, that urged us not to compare apples to oranges. And what it did, it evaluated 4 very common measures of multiple chronic conditions, specifically Medicare Chronic Conditions Data Warehouse, Charlson Comorbidity Index, Johns Hopkins Adjusted Clinical Group Scale, and Medicare Advantage list of conditions. And what they learned is that majority of these scales are actually including different types of chronic conditions. So if we were to there's not significant overlap between all 4 scales. So if my study is using Chronic Conditions Warehouse and Michael's study is using a Charlson Comorbidity Scale, we would not be capturing same chronic conditions. So when we're looking at the outcomes in terms of prevalence or the risk for rehospitalizations, we can't really compare our data because our indices are not the same. We also learned that not every measure of chronic conditions accounts for severity. For example, Charlson Comorbidity Scale does. That accounting for severity is a really key factor. We can't just be counting the number of conditions. It's relevant, but within itself, it's much stronger when we're looking at severity and the stages of diseases. So what we learned from this very large review of literature is Chronic Conditions Warehouse, the Medicare Chronic Conditions Warehouse, that's looking at the defining multimorbidity as 2+ conditions out of the list of 21 was the most sensitive. One of the big reasons why it was most sensitive is because it had a longer lifespan. It looked back, I believe, 12 to 14 months. Oh no, it looked back at a lifetime of a medical record within the Medicare system and counted up the conditions within a lifetime of the participant, where the Johns Hopkins ACG scale was only looking at a much shorter, more restricted time span within the medical record that conditions occur, but it had the highest specificity because it was looking at 119 conditions, right? So the wider the net, the more specific our findings are. What was very interesting is the two shorter scale, Charleston Comorbidity Index and the Medicare CSNP scale, both are 17 to 15 questions, had a much higher predictive validity for 90-day or for 30-day hospital readmissions. So takeaway points, we need to have a unified measure of multiple chronic conditions if we want to compare our findings and if we really want to understand what is happening in the field. And if we don't have a measure that's considered to be kind of gold standard and we all agree is like the best measure to use, then we need to select measure based on what our outcomes would be. So if we are studying hospital-based transitions and readmissions, we shouldn't be using Medicare Chronic Conditions Warehouse because it would not have predictive validity to kind of tell us how likely the person is to be readmitted, and we wouldn't know how to triage our services and what people to identify to give them extra attention and to enroll in our transitions program. All right. We also learned that there's some conditions that have the highest predictive power. So liver disease, kidney disease, and metastatic cancer had kind of the highest predictive power. So we want to be using scales that include those conditions. Polypharmacy is another big side effect of multiple chronic conditions because the more chronic conditions, the more medication. The more medication, the higher the chances of potentially inappropriate prescribing. So we all know that polypharmacy increases the risk of adverse reactions, the risk of death, the risk of morbidity. And there are actually very few tools that allow us to assess potentially inappropriate prescribing, specifically in people living with dementia. And there was a really wonderful literature review, pretty comprehensive done. You have reference here at the bottom of the slide that evaluated multiple tools and said that the best tool got to account for drug-drug interactions, disease-disease interactions, and disease-drug interactions. So one of the most commonly used criteria, the Bayer's criteria, does not account for all those three and just lists medications that should not be given to older adults, kind of due to anticholinergic and other potential side effects, but it's not comprehensive enough to be really effective in identifying and addressing potentially inappropriate prescribing. So the measure that our study team identified and that I would suggest to you and that I use clinically now myself that I think is probably more comprehensive, though a little bit more labor intensive, is the stop and start measure. This is the measure that accounts for drug-drug, drug disease, and disease-drug interactions and has algorithms that help you identify what medication should not be used in this particular person based on their comorbidity profile, based on all other medication they take and other factors. And it has a very good list of medication most commonly used in dementia. So I think this particular measure is excellent for dementia. And I'll show you some kind of live data of how we use it in our current studies and what it looks like once you run medications through this algorithm. And the very last term that I will define for you before we kind of go into some examples of living with dementia and multiple chronic conditions is ambulatory care sensitive conditions. Ambulatory care sensitive conditions are defined as conditions for which good outpatient care can potentially prevent the need for hospitalization or where early intervention can prevent complication of more severe disease. And it is believed that if we treat ambulatory care sensitive condition optimally in outpatient setting, nobody should ever be in a hospital for one of those diseases. And on the right here, you can see the list of some of the most common ACCs. One of the measures that generally used and adopted in most ACSC studies, was developed by Agency of Healthcare Research and Quality. And there's a lot of other studies that kind of add or subtract, but this is kind of a core list of ACSCs. What we know about ACSCs in dementia is that people with dementia are 2 to 5 times more likely to be admitted to a hospital for one of those ACSC conditions compared to age-matched adults. So if you're not supposed to go to the hospital for these conditions ever, and if dementia puts you up to 5 times the higher risk, it's a very big problem for our healthcare. And we also know that 3 specific ACSC account for almost 2/3 of all potentially avoidable hospitalizations, and they include pneumonia, congestive heart failure, and urinary tract infections. What we also know, sadly, is currently we don't have any proven disseminated and broadly used interventions that prevent ACSC admissions in dementia. And all the literature is pointing out to real urgency for developing intervention that's specifically targeted for preventing these potentially avoidable admissions for people who are living with dementia. If you think back to the beginning of our talk and me telling you about the state of science about multiple chronic conditions, you're probably thinking, what would be putting persons with dementia at higher risk? Any thoughts in a group? What puts a person at higher risk? If you have dementia, why would they have more of those admissions? Anybody? Michael.
So it may go undetected longer and be more severe.
Excellent. People with dementia are less likely to be able to report their own symptoms. The symptoms the presentation is very ambiguous, so they go undetected and therefore more severe, leading to an emergency hospitalization. So this is an exact theory, hypothesis that our team's been working on exploring for the last 2 years, and I'll show you some data. So our current work, and thank you, Michael, for this beautiful transition, is really looking at understanding ACSCs in people with dementia and ACSC-related hospital admissions. And our question was, okay, so there's been a lot of Medicare demonstration projects. There's been a lot of excellent, solid care coordination projects that did not kind of pick up and get broadly disseminated to stop these potentially avoidable hospitalizations in a community setting. So we thought, what is missing? And what we identified was missing from the literature is a look at what happens at home and what happens specifically with the care partners, with family members of people living with dementia. So we hypothesized that if care partner could identify this exacerbation of chronic condition that leads to potential ACSC-related admission early on, and if they can record and report the symptoms and communicate with healthcare providers, then we're going to give excellent healthcare to people at home, and then nobody has to go to the hospital. So this was our hypothesis. Our other hypothesis was, and I'll tell you right now, right off the bat, none of our hypotheses came out proven in the way we thought they would be by our data was looking at 100 cases of ACSC admissions. So now you have the takeaway point. Our next hypothesis was that a complexity of a person with dementia would really affect care partners' ability to know and understand medications, to know and understand multiple chronic conditions, to be able to kind of recall healthcare encounters and to manage successfully healthcare encounters. We figured that if a person is on 20 medications, has 15 different conditions, and a lot of things went on, those would be care partners who are going to need a lot of help and a lot of triage of services. And we didn't find in all cases that this was the truth. So what we set out to do is to do this to take 100 steps backwards and to understand what has happened and what were some opportunities for intervention with a person living with dementia, with their care partner, and maybe with healthcare system that maybe would have prevented some of the admissions. So this was the study that we did. So why care partners? Why do we care about caregivers or care partners who are living with their loved ones at home? Well, there is almost 15 million care partners of people with dementia in the United States. And I really love this quote that says that all of us are our care partner will be a care partner at some point. So very, very important to understand care partners and our needs. To start to understand how we can best engage care partners to reduce the adverse effects of multiple chronic conditions and hospitalizations in people with dementia. We actually started this journey many, many years ago. We had to develop measurement. We had to kind of figure out, what do care partners know and what do they think they know, and how engaged are they in managing medical needs of their loved ones. So we developed a measure, we call it MILO, or Managing Your Loved One's Health, and that's a measure of care partner activation. We define care partner activation as a process of gradually becoming ready to take on caregiving roles, and then developing necessary skills and knowledge for managing health needs of the care recipient, and also managing your own wellness, because you can't really be doing everything for somebody else when you're not taking care of yourself. So that's one measure that we developed. And then we thought, okay, there's so much need. There's so many care partners and their loved ones that require enhanced services. How do we find people that we need to intervene with right away? Who do we get to first? So we had to develop a very brief 5-minute screen of, we call it the Dementia Services mini screen, of if we have scarce resources, how can we in under 5 minutes identify who they need to go to? And we developed a measure that includes the stress thermometer developed by my mentor, Dr. Sue Borson, that measures care partners' stress at this point in time, and a list of behaviors that care partners report to us are most troublesome to them, behaviors in a person with dementia. And we validated this brief screen as a pretty good triage measure, knowing that if behaviors are high and if stress is high, then we really need to be intervening pretty quickly to avert crisis. Then we went alone and we developed some single item measures. How do we know if care partners are ready? How do we know if they're willing for caregiving? How do we know if they're prepared? And then we learned that adding few questions about care partner wellness is not enough. We got to have the whole new scale, and our current work is in developing this whole new scale of how well do care partners take care of their own needs from day to day and in crisis. We also validated a clinically relevant multi-domain measure of care partner stress, and kind of define a role for care partners in a chronic care model. So here's a classic chronic care model. We have engaged and activating healthcare team. You have community that's engaged and activated and supportive. And then you have informed and activated patient. Well, a person with moderate to severe dementia can only be informed and activated to a degree. So we really kind of added informed and activated care partner for those who are living at home, which majority of people with dementia do live at home and are cared for by family members, as a big and important part of the chronic care model of a team. So, okay, so now long-awaited anticipated findings from our current work. We set out to look at 100 cases of people who had medical diagnosis of dementia in their medical record, who were admitted to Northwest Hospital, UW Medical Center, and Harborview Hospital, so all of our local UW-affiliated hospitals, with primary diagnosis of an ACSC. And what we wanted to do, we wanted to reconstruct all the steps of what has happened from the moment care partner, and all the patients lived at home, from the moment care partner noticed that something was wrong, and all the decisions that they've made, all the thought that they had, all the healthcare interaction that they had, up till the point patient was hospitalized for one of these potentially avoidable hospitalizations, and to really follow them through the hospital course too, and to ask some questions. So we were doing this kind of reconstructive study of what has happened, and we really wanted to fill in the knowledge gaps of what went on. We also wanted to do some clinical validation of measures that we previously developed. So we developed a measure, as I mentioned earlier, of caregiver activation, managing your loved one's health, that psychometrically just was solid. It just psychometrically looks fantastic. But we, as a clinician, as a practicing clinician, I always ask, how does caregiver know what they don't know? How do they know if they know medications? How do they know if they know chronic conditions? How can I, as a clinician, go by what they tell me if they may not know that they have knowledge gaps. So part of this study was set out to really compare data available to us from patients' electronic medical records to how caregivers assess their own knowledge and skills, and to have some really objective evidence about the state of things that have to do with potentially avoidable hospitalizations for people with dementia and multiple chronic conditions. All right. So here I'm just giving you a little bit of information about the study. We measured a lot of different things. And we also conducted very rich, very rewarding interviews. And the brains behind our operation, Emily Shadow, is here. She is a study coordinator on this study who's done probably majority of those interviews and collected amazing hours and hours of data for us about caregivers' experience of noticing that something's wrong and then living through the experience of this hospitalization. So a lot of quantitative and qualitative data. We also adopted a measure that was developed for long-term care, and some of you, if you work in long-term care, you may know it's an excellent measure. If you're not using it, you should be using it. It's called Stop and Watch, and it lists a number of ambiguous presentations in different categories. You know, are there changes with ambulation? Are there changes in skin? Are there changes in appetite? Really systematic way to monitor baseline so you can notice when something is wrong. So you really know that something is not right, even though it's not clear what it is. So I adopted this measure for use with our caregivers when we asked them to recall what they noticed, because we had a hunch, and literature pointed out that presentation of some of this acute exacerbations of known conditions would be vague, but nobody ever really operationalized it and really gave us concrete data of what does this vague look like. So we had a vague measure that everybody reported to, and I'll give you some of this data in a minute. Okay, so we also looked at, exhausting just to tell you everything we looked at, but we also looked at 30 days of all electronic medical record, inpatient, outpatient, everything leading to hospitalization. And we created timelines. So per electronic medical record, what were the interactions between caregivers and healthcare system? Like what was reported, what advice was given, was primary care provider or outpatient team involved in decisions to hospitalize? And then we kind of superimposed these timelines and encounters that we created to what caregivers reported to us, to be able to see how well does caregiver recall, and is there kind of agreement or coherence between what caregiver heard, maybe the nurse told them on the phone or primary care told them during an appointment, and what was in electronic medical records. So we're doing a lot of detective work trying to look for inconsistencies, consistencies, and coherence. We also identified most recent problem list, medication list, in order to be able to get some objective understanding of what caregivers know and don't know. And another very key factor, we really wanted to be able to operationalize in how many of this out of these 100 cases was dementia used as an organizing principle of care. And like, what does it mean to use dementia as an organizing principle of care? If we look at dementia as an index disease, if we think of this comorbidity, what does it mean? And some of our participants were receiving specialty geriatric care and were followed in memory disorders clinic. Majority weren't. So we were really looking at how do we define that. So we very carefully looked at care plans and inpatient, outpatient care plans to see, did they include the care partner? Did they talk about that person has dementia, and if it was a specialist who was seeing our patient for exacerbation of kidney disease, we were looking very carefully at the notes to see, did they kind of mention in the note that person has dementia and wouldn't be able to follow, a plan for reducing and limiting hydration. So we're really paying attention to all those things. All right. So, and then something we're still working on, we looked at the literature that exists to date about what are the risk factors that are likely to put a care partner and a person with dementia at risk for adverse outcomes. And we kind of collecting all this data systematically on the 100 cases, trying to see that if we were looking at, let's say, an intervention within our kind of statewide healthcare system, can we get some data from electronic medical records that would help us triage, who is going to be probably the first candidate for the scarce resource for the intervention? And here's some variables that we looked at. Does care partner live with person with dementia? How many years they've been caregiving? What is care partner stress and anxiety? What is the number of chronic conditions that person with dementia has, as an example? All right. So preliminary findings, what did we learn? And I want to apologize in advance because we have very different sample sizes for a lot of different data sets that I'll be showing you, because we are still collecting data. As of today, we're at 93 over 100, and we're analyzing everything in batches, and some analyses are more complex. So when we are triangulating data from measures, caregiver interviews, and EMR, we have a much smaller sample size to report to you to date versus when we're doing descriptives for everybody who is entered into our system. So we'll start with 84 for descriptive. This is what our sample looks like. What you notice, our people with dementia are older. They're very multimorbid. And they have a Charlson comorbidity scale. Thank you very much, Ann Hirsch, who faithfully calculated for all 84 people, almost single-handedly. They have 8.9 average comorbidity scale, which is giving them almost 0 survival chances for 10 years. So again, we're looking at the group of people who truly meet the criteria for palliative care intervention, because most of these folks have 0% risk, 0% chance of surviving past 10 years. So truly, this is a very palliative care eligible group. Our caregivers are primarily spouses and children. And average time becoming caregiver is almost 7 years. You know, they've been doing this for a very long time. So that adds strain. And if you notice here, 31% are still working full time. So how, I don't know. It's very, very tough. So here I just create a word cloud for you to show you some of the most commonly captured ACSCs, or ambulatory care sensitive conditions, in our study. And again, the larger the word, the higher the prevalence in the sample. And UTI, pneumonia, altered mental state, and hypertension were some of the drivers of ACSCs, followed by heart failure. And here's a list of the ambiguous symptoms from the stop and watch measure. So we ask everybody, when you notice something was wrong, tell us exactly what you saw. And a picture would be like, he wasn't doing well, and then he was doing worse, and then he was really bad. And that could be a description of UTI, pneumonia, altered mental status, hypertension, ulcers, you know, everything on this list would have pretty much that explanation. So when they come to your ER, or when they call you, if you're primary care doc, if you get a picture of, my mom wasn't doing well yesterday, and today she's doing really bad, and right now she's like really, really awful, you don't have much to go by. So then we decided to quantify the ambiguous symptoms for you a little further. And as you can see here, 100% of people ate less. 77% of people seemed different than usual. Half of them communicated less. 62% needed more help. 60% needed help with ADLs. So here you go. This is the presentation. You didn't get chest pain. You didn't get shortness of breath. You didn't get, diaphoresis. You got that. So would you not admit this person when I say, my mom is dying? I'm sure she's dying. She has all that. And she didn't have all that, last week. It makes us question potential avoidability of ACC admissions from the time that symptoms first appear, right? And I'll talk to you a little bit more about when we think these admissions are avoidable, and we believe that avoidability needs to be built in much, much earlier than when symptoms start to exacerbate. So here was one of the biggest heartbreaks for me, because I had this solid hypothesis that the complexity of a person with dementia would really affect care partners' ability to know what to do and to understand medications and chronic conditions. So here on this graph, you're looking at smaller group, just 30, of care partners whose loved ones here, where I'm pointing, had just 3 to 6 chronic conditions. And here we have care partners whose loved one had up to 13 chronic conditions. And we would think that when somebody had just 3 chronic conditions, you should know it all, and they did. Well, when they had 4, their knowledge was actually lower than for those in a group who had 13, 12, or 10 chronic conditions. So this hypothesis of if my mom just has diabetes, I should know everything about it, versus if my mom has 13 different things, so far with a small sample of 30, it didn't get proven. To be continued. If you invite me this time next year, I'll report on 100. But for now, the trends are showing that there got to be other things than just a complexity that's driving care partners' knowledge. Here we have knowledge of medications. Again, those who had, 0 medications knew them all. Those who had 1 to 2 medications had various degree of match between of what they thought they knew and what they actually knew. And we have here people on 12 to 15 medications that have a perfect match. They knew exactly all the medications the person was in. So again, something other than complexity is driving it. And then we ask for purpose for medications. Like, do you know what they're for? Because it's one thing to read off the list. All our participants had access to med bottles as a list. We weren't testing their memory. We were testing their ability to access the knowledge that they need to know medications. But then it was tough, and nobody had a list of what, the Jackson is for. But we asked them, for what condition is it given? What is it for? What to expect? And again, very weird findings. Early small sample, but weird. The fewer medications and the more medication, the more like this total perfect match. In between, a much lower match. So to be continued. And in the bottom here, this is percent match that they had. All right. And then also gets interesting that we were trying to kind of match the chains of events from, is caregiver able to recall all the healthcare encounters that happened from the time symptoms emerged to hospitalization? And is there kind of match in what they think happened, what they said happened to what's in the EMR? And again, the number of encounters, and I'm sorry it's a little light here, the lighter green so you can't see very well, but bottom line is the number of encounters didn't seem to really affect the match between what caregiver recalled and what has happened based on the EMR. So we're really looking forward to kind of entering all our data and looking at a large sample of 100 to see what accounts for all of this. If it's not complexity, then what? And then we applied the stop and start measure to all our cases. And here I'm happy to report to you on 64. Actually, I'm not happy to report to you. I'm very sad to report to you because these are the folks who are within our home healthcare system. 31% of them had at least 1 stop medication that either was drug-drug, drug-disease, or disease-drug interaction inappropriate. 20% had 2 inappropriate medications, and 2% had 4. And here's the biggest offenders. Again, the larger the font, the more frequent is the offender in our sample. So furosemide, donepezil, zolpidem, aspirin, citalopram, olanzapine was some of the most frequently appearing medication that had some kind of contraindication based on stop and start criteria. Then we asked everybody a list of palliative care best practice questions. And this is really important because all the hospitals from which we recruited have palliative care service and have a geriatric care service. But if you are able to kind of print out your handouts large, and probably in the slide would be hard to see, but take a look, very few people actually received referrals to specialty services. What's also is really disheartening is when we ask people here, did healthcare provider ever explain to you what is the normal progression of dementia? Did anybody kind of tell you your loved one has Alzheimer's disease, now it's in early stages, but this is what we kind of can expect over the next few years. And your loved one also has asthma and COPD and anxiety disorder. And this is how, as cognition continues to worsen, we kind of expect some of this management of these disorders is going to be affected. We basically ask a very simple question. Did healthcare provider ever explain to you what to expect with dementia? And here you see green is no, and blue is yes. Now, this is among 84 people in our healthcare system. We are not doing a good job telling people what to expect and preparing them to manage multiple chronic conditions and dementia at home. Also, green is no, blue is yes. Do you know the stage of dementia? Same here. Do you know the type of dementia? And we even had about 11% of people, everybody have EMR diagnosis of dementia. Care partner had no idea person had dementia. So again, not doing very good job with that. So what are some key lessons that we learned from this very preliminary look at our data is that primary reason for hospitalization outside of the ambiguity of symptoms was that persons with dementia illness exceeded care partners' capacity to care at home. They watched, they waited, they watched, they waited, and then they decided that it would be reckless for them to watch and wait. And that's kind of the biggest takeaway point. Most hospitalization for ambulatory care sensitive conditions in our sample, and we took a very close look at just 30 cases so far, we could find this different, but in our first third of a sample, are not avoidable if we were to intervene at the time symptoms started to appear. What we propose is that intervention has to be planned and take place much, much earlier. For majority in our cases, dementia was not used as an organizing principle of care. Dementia was not really mentioned in specialty notes or in a lot of primary care notes. It's on the diagnosis list, but none of the care planning is really accounting for person having this dementia and the consequence for it at home. Most care partners do not practice self-care, especially when in crisis. Therefore, they can't really sustain the work that they need to do. Most care partners also overestimated their resilience. Everybody say, I'm super resilient, but when we ask them specific questions like, how did you manage the situation? And it seems like you're still really affected by the stress of hospitalization. How are you coping? We learned that they weren't so resilient after all. So we're fortunate to work with a brilliant social work student, PhD student, who is now developing a behavioral measure of care partner resilience, where we can actually look at some problem-solving, help-seeking behaviors and to kind of identify if somebody needs a little bit of a help with being more resilient in different situations. Clinicians did not discuss what to expect in progression, in kind of an expected progression of dementia. And care partners really lack knowledge and skills to implement treatment prescribed for people living with dementia and don't accurately report or estimate their knowledge of multiple chronic conditions, their knowledge and skills of medications. Majority of symptoms were ambiguous. We quantified this ambiguity, and they were very fast evolving into crisis. And this fast evolution to crisis is what really led to the hospitalizations. And palliative and geriatric care referrals were drastically underutilized. So by the time we're done with this study, we're going to be developing in-depth case reviews where we're triangulating data from caregivers' measures and medical records. We're going to operationalize what does it mean to use dementia as an organizing principle of care. And we kind of go about it from a roundabout way. We're looking at what wasn't done by doing detailed reviews of what has been done and working backwards, saying what should be done. We're also developing this checklist, this triage algorithm about patient and care partner characteristics that we may find in electronic medical record that can help us flag people at highest risk. And we're developing a menu of tailored interventions. So what we're doing for the small subset of people in our study, of people with dementia, multiple chronic condition, and ambulatory care sensitive hospitalizations, we're looking at just a subset of 30 right now, and we're learning everything to learn about that case. We are doing the detailed systematic summary of electronic medical record, detailed search of caregiver interviews, really figuring out what measures of, that we got from caregivers and patients tell us. And then we're putting together this story. It's literally like a one-page story of what has happened, and we're drafting an intervention. So if we were to come in today to work with this dyad, what would be caregiver-related intervention? What would be person with dementia-related intervention? And what will be the health system intervention? So we're kind of creating this menu of interventions and thinking of a timing of these interventions. And what we're learning is that timing has to be way before the symptoms start exacerbating. There gotta be an organizing plan in place way prior to that. So we're also going to be developing a companion to our current measure of caregiver activation, basically saying it's not enough to ask caregivers how well do you know medications and chronic conditions. You need to really kind of quiz, go down the list to find out their understanding and offer appropriate education. And we're developing a comprehensive measure of caregiver self-care and self-management. All right. So some solutions that I can outline to you kind of early on right now, just based on our preliminary data and review of the literature, is we got to consistently assess the needs of both people with dementia and their care partners. And we need to start assessing them early and their need for knowledge and skills, their need for our support, and not just psychosocial interventions, but also kind of biomedical interventions, and if you're looking at just some of the national reports that came out in the last 2 years, most care partners are performing some type of nursing medical tasks at home, and most of them don't feel like they receive sufficient training and coaching and kind of ongoing help with performing those tasks. So we need to be assessing those skills. We need to do more teaching. We need to iteratively assess care partners' understanding of person with dementia, medications, and chronic conditions, especially as their health kind of evolves and worsens, and especially when multiple chronic conditions are taking place. We also need to kind of cultivate partnership. We need to empower our care partners to talk to us as clinicians, and we as clinicians need to be kind of taking this first step. We need to really systematically teach care partners what to watch for and what to report. We're really looking forward to doing a deep dive into our qualitative data, but what we're hearing from the interviews, again, 100 cases, we're hearing over and over, oh, I didn't want to worry or bother my loved one primary care provider. That's okay. The one that's really tragic, I didn't want to bother calling because every time I call, I get a different person, and every time I take him in, if I don't wait for a month to get in to see his doctor, I see somebody else. They don't know him anyway. I might as well go to emergency room. So neither one of those scenarios is really creating the partnership that is necessary for successfully managing multiple chronic conditions in people with dementia. And that's what lands people in hospitals. And that's what exacerbates not only healthcare costs, but causes our patients' lives. They frequently come out with nosocomial infections. They frequently come out with falls and fractures and complications. And most people with moderate to severe dementia after hospitalizations would develop some superimposed delirium. It's just that hospitalization itself is so stressful in a fragile ecosystem that just doesn't have as much resilience. We need to have early and ongoing goals of care conversations. We're very fortunate to have Dr. Brock Gaster working with us in our team, and he's kind of started this movement towards really helping to systematically conduct goals of care conversations with people with dementia. Well, our preliminary data is showing that we don't do enough of that, and this goal of care is an evolving conversation. It's not that you have it once, It's a really conversation that needs to be ongoing. We need to define and to operationalize dementia palliative care from diagnosis to death. Dementia is a terminal disease. There is no cure. It's a palliative care condition that requires specific palliative care approaches. And hospital at home is really a concept that really need to be implemented more, need to be studied more, and could probably be really cost effective if we do it correctly, where we don't make people with moderate to severe dementia come out to multiple specialty, multiple appointments, where we really bring in home health to them in a true sense of the word. Home-based primary care is another very important concept. A lot of times when we asked our care partners, if doctor would make or a nurse would make a house call, would you use it? And again, this study was full of surprises. Most of our hypotheses got disproven. Emily's smiling because, Emily is a geriatric social worker. She's, seen these families. I maintain geriatric practice. I see these families. And we all just very strongly thought that every care partner would say, of course, if somebody can come to my home, I would use it. I would welcome it. A lot of our care partners said no. And when we prompted them and said, why not? They said, well, what can they do? They can't do anything without running like invasive and extensive labs and imagings and things, what they're going to do, they're not going to just come like look at him and tell me what to do. They're going to come look at him and say, yeah, he looks really bad, let's call 911. And that's a perception. So this idea of hospital at home, of home-based primary care, where we're actually treating and diagnosing, or maybe even bringing up some mobile labs if we have to, but kind of going back to good medicine, symptom-based medicine, and knowing the patient, and really where treatment is very much guided by us knowing the patient, really seems like we have to take 1,000 steps back to go back to that as a solution. All right, so what are we doing next? We are developing an intervention. Again, we're taking everything we learned from this study. Once we understand everything we learned from the study, again, we're just finishing up, and we're going to identify what is a group of people that we are likely to be able to maybe help prevent an ACC-related admission if we start very early on, 1,000 steps back. And if we were to intervene for people who just experienced potentially avoidable hospitalization, what would be caregiver patient health system level interventions that we learned we think could be successful? We're actually going to try to implement them and to see if they're successful. And hopefully, next study would prove all our hypotheses. We're developing a system of kind of triadic goal negotiation, where patient-enabled care partner and a clinician will be negotiating goals and outcomes. And we really want care partners to take a very active role in identifying their priorities. So we really believe that we can go being prescriptive. The care partners are doing a lot. They know a lot. We need to treat them as true partners. So with clinicians going to identify, I'm sure, a long list of things we think needs to be intervened on, but we want care partner to say what's most important to them and what is the outcome they want to see. And as a team, we're going to try to take them through to accomplishing those outcomes. We want to use technology to really increase translatability of this work. Again, there's not enough of this work on medical management and very practical medical management of people with dementia and multiple chronic conditions exists. So we feel a sense of social responsibility to not just doing a small, expensive study of 20 people that may or may not in 17 years become disseminated somewhere. We're thinking of like, how can we utilize technology and other things to help us now? So we're developing a proposal to use TVs, working with a company that has developed a platform where any television set with HDMI cable can become this virtual portal of communication between researcher, clinician, and a care partner, and have automatic set of reminders and prompts and check-ins. So we're kind of exploring to see how feasible that would be in this intervention that we're envisioning. And we're going to be continuing to test and perfect our care partner needs assessment battery. And we're hoping to really implement this iterative assessment, the use of technology, and this type of iterative goal setting and care planning to support a funded, Medicare-funded care plan code 99483. So late last year, Medicare approved a billing code where once a year, primary care clinicians are able to receive a fairly good payment by billing this code for gathering required data element for person with dementia and their care partner. This care planning code is not broadly used as of to date because there's so many data elements you need to collect and report on to be able to bill. That's kind of almost impossible within the constraint of the time that allocated for appointments. So we're hoping that the assessment battery that we created and automated can collect a lot of the care partner data that's required for this billing code. It can be collected prior to appointment. So during the appointment, some key questions and clarifications can be asked. So we're kind of exploring usability of that. And I just want to thank our research team, specifically Dr. Sue Borson, who's been my mentor and collaborator since I was an undergraduate nursing student, and who really inspired a lot of this work, and our wonderful partners, Laura Gitlin, Kitty Buckwalter, and Artis Dorenbos, who's helping kind of our team develop our new expertise in palliative care and interventions. So I think we have time for questions.
A couple of my own, if you don't mind.
Absolutely.
One is, I know you're going to add a resilience measure, but I'm wondering if you've characterized your care partners more broadly for issues like medical burden, depression, socioeconomic status, to see if those factors may help
Absolutely.
address?
So that's the plan for once we get 7 more people and we're at 100. The issue of medical burden is interesting. There's very few good measures of medical burden that's specifically tailored to care partners. And it's a very interesting concept, but if you have suggestions for a good measure that's designed for care partners to kind of really understand, other than just quantifying number of conditions and medications we already done, that would be important. But I mean, there's so much more to medical burden than just in the count of things, but we have a slew of care partner and patient characteristics that we're going to be running a lot of kind of correlation analysis to understand what are some associations. We're developing hypotheses right now. And it would be large enough sample where I think we can see some good trends.
Okay, and then my second question, and this is, of course, from my own personal lens. In your various lists of illnesses that can be comorbid, one thing that was missing, from my point of view, was sleep disturbance, insomnia. And the reason I ask that is because sleep disturbance is common in dementia disorders generally. And also there have been a number of studies that have looked at institutionalization of an individual who has dementia by their caregiver, my old term, caregiver rather than care partner. And one of the major factors that came up was the fact that the care partner's sleep was disturbed by the individual. And as a result, their ability to cope with the situation was problematic. So I'm wondering if, I don't think you've added that, I don't think you've looked at that. I'm wondering if you might consider adding that going forward.
That's an excellent point. So the reason why we're not looking at insomnia as one of the ACC diagnoses is because it's not on the official diagnosis list, and because most people don't get hospitalized with diagnosis of insomnia. They may hospitalize with diagnosis with delirium or altered mental status because their circadian rhythm is disturbed for the patient, and that results in slew of kind of behavioral and kind of neurological manifestations. But it's a very good point to add insomnia to kind of thinking of a list of medical burden for care partners when they sleep and their loved ones sleep.
Yeah, I recognize it wasn't in the model, but it might be something
That's an
that could be
excellent point.
telling
Thank
anyway.
you.
Especially if you work with Sue, because I know she's sensitive to sleep questions. We have a question from outside there. Is there a specific age range for the ACSCs?
No, there's no specific age range. In fact, ACSCs, ambulatory care conditions, were first developed to address inappropriate hospitalizations in children. So this whole kind of movement started with trying to prevent children from being hospitalized for asthma and kind of conditions that really should be managed outpatient. And then it kind of evolved into application to adults and older adults.
And then another question, are you only looking at people with dementia who are living at home? Many of our clients with dementia live in adult family homes.
Correct. So we are only looking for this particular study at people with dementia who are living at home because, again, our goal is to try to understand how to support their care partners who are caring for their loved one at home. We did an earlier study when we were looking at assessment of the needs of care partners in hospice, and some of the participants, majority of participants were living at home and receiving hospice services. Some lived in adult family homes, very few, but just from this small sample we learned that ultimate decision making in terms of engaging medical services, and especially acute medical services, was a preview of adult family home staff in those situations. So because we kind of wanted to really understand how we can best support a primary decision maker who is engaging medical and acute services, we decided to focus on only those who live at home or who may be living in assisted living, but an independent living, and have a care partner who doesn't have to live with them, but is engaged in managing their medical care.
And in your study going forward, would you stick
To have
with
one
that?
more participants.
Any questions here? Yes, please.
So I have questions related to my current long-term care experience. It looks like the current service are more focused on really the early stage of dementia than really late stage of dementia, because I found that the mid-stage dementia patient, for example, if they have history of getting lost and they are not will not be accepted by some like dementia assisted living facility, and they are staying at home and they are tending to like hospitalize like for like long period of time until they go into the really late stage of dementia so that they can go to the nursing home or something. So do you have any like research shows that the mid-stage dementia patients are tend to be hospitalized in current United States?
Research about stages of, so that would be difficult because when we look at electronic medical records, most of them do not stage dementia. You know, dementia would be listed as a diagnosis, and sometimes you would have you know, some notes in the electronic medical record that may say terminal stages of dementia, but they really do not list the staging when you look at diagnostic codes. So I don't have epidemiological data to show you that moderate stage of dementia has high hospitalization rate. I think that you would be correct that probably moderate to severe dementia probably would have higher hospitalization rates. And maybe moderate would be even highest because with severe stages, a lot of people eventually go on to hospice. Though qualifying person with dementia for hospice is very tricky because, you know, hospice criteria is you need to have impending death within a certain period of time. And with people with dementia, it's very difficult to predict that, and a lot of people come on and off the hospice service.
I have another question from our remote audience. What is your definition of secondary care versus primary care?
So I'm thinking about, so primary care, good question. Secondary care would be focused more on prevention. So what services do we have in place that would be more preventive? And primary care would be a traditional definition of primary care that's addressing the immersed need. Does anybody in the audience have better definition of primary versus secondary care? Oh, I said your primary care would be addressing kind of your emerging needs, and secondary care would be focused more on prevention. So I would say that, you know, getting your flu immunization, I would consider to be a secondary care, and coming into a clinic for a flu would be primary care in my definition.
Okay. You can probably close the door the rest of the way, and that'll help us. Another question, please give examples / expand on how to define or operationalize dementia palliative care from diagnosis to death.
Well,
there's an expansive question.
Yeah, you're asking a very expensive question. So I believe that dementia palliative care from diagnosis to death first starts with early diagnosis. And that's, again, very critical need because a lot of people with dementia don't get diagnosed till there was some kind of crisis that occurred, whether it's with their neurological, mental health, or physical health. So we need to be diagnosing dementia early on. And then we need to start having goals of care conversation with the person when they're fully able to contribute and fully able to tell us their preferences, their likes and dislikes, and their wishes kind of for the rest of their life. So when people with dementia enter stages when they're not able to cognitively contribute to that conversation, we were able to capture their needs. Then we start, you know, we offer a comprehensive physical assessment. We offer a comprehensive care partner kind of coaching and education and helping care partner transition from husband or wife or daughter or friend to eventually taking on care partnering responsibilities. And again, that's a process. Definition of palliative care is to offer kind of comprehensive enhanced support to patients and families for patients who are suffering from conditions that are severe or incurable. So you start very early on, and that you maintain communication. You offer both psychosocial and biomedical services for both members of the dyad, for patient and the care partner. And then you see them on a regular basis. You don't just see them once a year. You know, you check in with them. You offer, you know, primary care at home, hospital at home options. You offer home health options. You evaluate people for when they need respite care early before they totally break, and you know they're making decisions to hospitalize, to institutionalize or hospitalize. You know, we encountered some cases where care partner was just so burned out, and they were looking at a hospital, you know, as a almost respite because they needed a break. And then you consistently kind of assess and tweak and offer help. and you see them through to death and after death of a loved one, because one of the things we learned through our studies is care partners, it takes them a while to redefine themselves as a care partner, and once they do a really good job at it, and they totally identify as the care partner. A lot of them completely abandon their primary identity, and all they are is what I mean in my relationship to delivering care for my loved one. And when loved one dies, they're out of job, and they have to find themselves and redefine themselves again. So I should put in the slide that good palliative care would be from diagnosis to beyond the death of a person with dementia, because this is when special support needs to be given to care partner.
Okay, thank you. And another question came in. Do you consider care partner a home health aide if the home health aide spends the most time with the person with dementia, or are care partners only unpaid caregivers?
So for the purpose of this study, we define care partner as an unpaid caregiver, but care partner is anybody who's partnering with a person to improve their life, you know. We had to kind of set criteria for this particular research study so we can enroll a uniform group of people, but I think general definition expands to whomever is partnering to help.
Anybody out there, type in your questions. It's we're running out of time. I'm wondering if anyone else here has a question. Meanwhile, why don't we wait 1 second to see if something else appears, and if not, we'll call it a day. Well, I'd like to thank you, Dr. Sadak, very much for this presentation, and for all of you out there, we'll see you next week for the next round. Thanks a lot.
Thank you for your attention.